Okay, so I think we'll get started because we have a very tight schedule and I don't want to get behind time. So thanks very much for coming to our session on new medications. I'd particularly like the weather in Milan and the strikes in the Italian airport for improving our attendance today. Thank you. This is a very, I think, nice symposium that Andreas and I have been doing now for several years with the newest, hottest medications around that we're going to be prescribing over the next couple of years. And I think we have a very nice set of topics and compounds to discuss today. And just want to get started now by introducing Dr. Michael Rapacki. He's CMO of Horizon, and he's going to talk to us about a medication for borderline personality disorder, which is something that we all have difficulty treating. So, Michael.
Hello, I'm Michael Rapacki, Chief Medical Officer and Head of CNS Clinical Development at Horizon. I'd like to thank ECNP and the Scientific Committee for the opportunity to present actually the final results of the Portico trial to you all. These are our legal notices as Horizon is a publicly traded company in Spain. The etiology of borderline personality disorder is multifactorial, and recent research supports the role of LSD1 inhibition in the treatment of the disorder. Vafidemstat is an LSD1 inhibitor with an epigenetic mechanism of action that has been involved in neuronal plasticity, dendritic rearborization, axonal navigation, stress gene regulation, rescue of glutamatergic hypofunction resulting in improved sociability, as well as reduction of agitation and aggression, which are key features in borderline personality disorder. Across 10 trials with over 423 patients treated, vafidemstat has been brain penetrant, safe with no drug-drug interactions, well-tolerated, and does not have the side effect baggage common to atypical antipsychotics prescribed off-label for BPD, such as weight gain, sedation, sexual dysfunction, and extrapyramidal signs. The PK data supports the 1.2 milligram dose, and what I'd like to point out to you on the right-hand side of the slide here is the results of the target engagement showing that 1.2 was significantly improved over the 0.6. So Portico is a global phase 2, double-blind, randomized, placebo-controlled adaptive 14-week trial to evaluate the efficacy and safety of vafidemstat in a borderline personality disorder population. There were 211 patients randomized in a 1-to-1 fashion to either 1.2 milligrams of vafidemstat 5 days on, 2 days off, or placebo once daily over 14 weeks. There were multiple primary endpoints, not co-primaries, and for agitation and aggression, we used the Clinical Global Impression Severity focused on agitation and aggression, and for overall disease, the Borderline Personality Disorder Checklist. Considering there's no gold standard measure of pharmacological improvement in BPD, and because Portico was a phase 2B trial, various measures of agitation and aggression and overall disease were included to help us inform phase 3. Here is the study design of Portico. There were 12 weeks of active treatment. There was averaging of efficacy across weeks 8 through 12, and there was a 2-week subject blind safety run-out period. The main point here is the randomization worked. There were about 26% of patients in both groups on psychotherapy. They were in their early 30s, predominantly female, white, and of about average height and weight. Of note, Portico is the most real-world study of borderline personality disorder executed to date. So what do I mean by most real-world? We allowed various common comorbidities that are excluded in the other 18 clinical trials that preceded this, as well as other drugs that are typically exclusionary. And that felt like the right thing to do, because when you study a drug and you exclude everybody, and then it gets approved and it's turned out to the real world, you don't know how that drug is going to perform. We also allowed subjects to be on psychotherapy as long as we treated it like a concomitant medication. If they were on it, they had to stay on it. If they were not on it, they could not start it during the trial. Overall, measures of agitation and aggression and overall disease supported that the patients were sufficiently agitated, aggressive, and had enough disease. And the Beck Depression Inventory suggested that they were moderately depressed and they were clinically anxious on the State Trait Anxiety Inventory. I'm going to draw your attention across all the slides to the placebo rate from 0 up here on the left down to week 4 in each of the efficacy endpoints, because this was consistently seen regardless of endpoint. As seen here, there was no statistical significance on the CGI-S agitation and aggression across weeks 8 through 12, with a p-value of 0.2266 and a 12.2% reduction in agitation symptoms on this measure as compared to placebo. Overall disease improvement as measured by the BPD-CL, again, the noted placebo response out to week 4, and no statistical significance, although 11.2% improvement as compared to placebo. However, on the STAXI-2 trait anger, things look different. Of note, trait anger reflects how often angry feelings are experienced over time. For example, over the last 2 weeks since the last visit, as opposed to state anger, which has measured the intensity of angry feelings and the extent to which a person feels like expressing anger at a single time. As seen here, there was nominal statistical significance of 0.0071 obtained across weeks 8 through 12, and importantly, an overall average reduction of symptoms of 58.6% as compared to placebo. Of note, we discussed what would be clinically meaningful with BPD KOLs, and they stated that a 25% symptom reduction, regardless of scale, would be clinically meaningful to their clinical practice with BPD patients. Likewise, vafidemstat produced a nominally statistically significant reduction in overall BPD symptoms as measured by the best across weeks 8 through 12, with an overall symptom reduction of 30.9%. Of note, although the BDI-2 and the State Trait Anxiety Inventory were included as covariates, given depression and anxiety are the 2 most common comorbidities in borderline personality disorder patients, vafidemstat trended towards statistical significance with a p-value of 0.0944 and an overall reduction of depressive symptoms on the BDI-2 of 42.2% as compared to placebo. On a forest plot of all efficacy endpoints, all results favored, over here on the left, vafidemstat over placebo, which is like flipping a coin 12 times and having heads come up every single time. It can happen, but it is highly improbable. Of note, the effect sizes for overall disease on the STAXI, or the best rather, was 0.3093, and on the STAXI trait, 0.3755. So this was an analysis, a global statistical test, which is a multi-factor analysis, which essentially if the drug is working and the scale is adding something unique about the disease, looking at the patient from a different angle, the p-value should go in the right directions. If the drug is not working or the scale is not adding any additional variance, the scale will stay the same or get worse. The p-value will, rather. And as seen here, when you add the first two of the multiple primaries together, you start at 0.231, and by the time you get done adding in the Staxi, you're down to 0.0362. This was conducted to see if the signal was real and whether we could trust these results and whether we should move forward to phase 3. Regarding safety, treatment emergent events were slightly lower for those receiving vafidemstat. Treatment-related TEAs were similar between the groups. Those leading to discontinuation, drug withdrawal, drug interruption were low overall, 5 on vafi and 3 on placebo. TAs by severity were consistent between the groups with slightly more mild and moderate TEAEs for those receiving placebo. The majority recovered and resolved, and most importantly, there were no deaths in Portico, and the only TEAE with sequela was on placebo. These are the treatment emergent events that occurred by preferred term in at least 5% of subjects. I want to also point out there was one serious adverse event, a kidney infection in a vafi-treated subject. It was judged by the PI to be unlikely related as the patient had the symptoms as reflected in their laboratory results before their treatment started. The last thing I want to point out here is the intentional self-injury was lower for those on vafidemstat versus placebo as circled in red. So overall, the primary endpoint was not met by the FAS, but a trend on the PPS and the CGIS, agitation and aggression, was detected. 4 important pre-specified secondaries reached nominal statistical significance on the FAS, with clinically meaningful reductions in agitation and aggression of 59% and overall disease of 31%. These results are consistent with the phase 2A Reimagine trial in borderline personality disorder patients. Results across all the primary and secondary efficacy endpoints favored vafi over placebo. A global statistical test helped confirm that what we were seeing was real. Vafi was safe and well tolerated. There were no deaths or suicides. Suicidal ideation was low. And lower intentional self-harm events were found in treated subjects. I would like to thank you all for your time and attention, all the PIs, site staff, my Horizon colleagues, for their hard work and collaboration, and importantly, all the BPT participants who helped make Portico possible. Thank you, and I will be available following my presentation for any questions.
Okay. Thanks very much, Michael. In the sake of time, this is all very tight. I think that we won't take questions. All the speakers, if you could remain for a couple of minutes after your presentation, and those who want to ask questions can come up. And it's now my pleasure to introduce Professor Andreas Reif, who is the incoming president of ECNP.
Thanks a lot, Mark, and also a warm welcome from my side to our new medication session. I'm very excited to introduce our next speaker, which is Ravi Anand, Switzerland-based, but Chief Medical Officer from Neuron Pharmaceuticals, and he will give us details from a pivotal study on evenamide, a new mechanism of action in schizophrenia. Ravi, stage is yours.
Many thanks to you, Mark and Andreas, for this opportunity, and also to the ECNP. What I'm going to present are the results from a study that is unique in many ways. So this is the first trial, placebo-controlled trial done with a drug which is a glutamate release inhibitor. It's the first trial in which we're adding an antipsychotic to other antipsychotics with the intention of showing efficacy. And the study is done in patients with inadequate response, which is a very difficult population to treat. Okay, these are my disclosures. So the key features for evenamide, just to summarize them very briefly, it's a highly selective inhibitor of sodium channels, voltage-gated sodium channels that will be inhibited only when there's overactivity at those channel sites. Its effects on glutamate are such that it has no effect on basal glutamate, but only when there's an excessive release of glutamate, as can happen in patients with schizophrenia. It's been tested at over 150 different CNS targets, neurotransmitters, transporters, enzymes, and it does not interact with any of them, even at concentrations of 10 micromolar or more, although its maximum concentration in man is less than 0.4. It's been shown to be active in every animal model of psychosis, both as monotherapy and as an add-on therapy. Intriguingly, it rescues in animal models, when an antipsychotic is not working, the addition of this drug presents with efficacy in that model. Most interesting models for us are models in which glutamate antagonists such as ketamine, phencyclidine, MK801 produce worsening in PCP or in pre-pulse inhibition. And even when clozapine is not able to attenuate it, the addition of this drug attenuates it. Lately, we have been working with the MAM model from Tony Grace's lab in Pittsburgh, and it's produced phenomenal results. For today, it's just enough to point out that it's worked in all animal models of pre-pulse inhibition, in models of psychosis mania, negative symptoms, cognitive impairment, impulse control, and in the neurodevelopmental models, which are the MAM models. So this is a classic example of how it works. The white bar here represents normal pre-pulse inhibition. The addition of ketamine produces significant worsening in pre-pulse inhibition. Clozapine at a dose of 3 milligram per kilogram is not able to reverse this worsening. This drug by itself is not able to reverse this worsening at a dose of 1.25 milligram. But then when you combine the inactive dose of clozapine and the inactive dose of evenamide, you can see there's a significant reversal in the bar, which has got the double shades of green and blue. This drug given at a higher dose of 5 milligram per kilogram then reverses the ketamine worsening by itself. But then when you add the higher dose to clozapine, you get a much better effect. Again, it's telling us that in those situations where patients may not be benefiting from an antipsychotic, the addition of this drug produces a benefit which could be a therapeutic benefit. These are the studies done with the drug in phase 1, phase 2, phase 3. Most importantly, the highest dose has been identified as a 60 milligram single dose. A TQT study has been performed and showed no increase in QTC compared to placebo, rather than a reduction compared to placebo. It's been also shown efficacy in a 1-year open label trial in patients with treatment-resistant schizophrenia. And last but not least is the study that I'm going to present, which is a phase 3 pivotal study in patients with inadequate response who are already on a second-generation antipsychotic. So this study has been performed in Latin America, Europe, and in India, and it's a double-blind, placebo-controlled study. What is remarkable is that we know that adding one antipsychotic to another has never resulted in significant efficacy. This is the teaching in all guidelines and on multiple surveys that have been done. The population here is very much like the Katie study, where you also saw patients with about 10 years of disease not doing well, although not treatment resistant. There have been recently attempts to treat this population with many drugs, and not a single study has come out significant. So evenamide, a selective sodium channel blocker, was now added to second generation in patients who were not doing well. These are some examples of studies and surveys in which have looked at the effect of adding an antipsychotic to another one, and if you look at double-blind studies, high-quality studies, there's never been a study that is significant. And you have the Ochida-Fleischhacker paper, again, which reviewed all these studies and again came to the same conclusion that there is no benefit in adding one antipsychotic to another. So with that background, this study was designed, placebo-controlled. It's a 29-day study. Patients are randomized to placebo or 30 milligram BID of this drug. Patients are all meeting DSM-5 criteria for schizophrenia, all on a standard dose of a second-generation antipsychotic. The symptoms must have been florid and present for at least 1 month. The PANSS score was between 70 to 85, and CGI ratings had to be at least moderate to get into the study. Patients were rich with core-positive symptoms, and after 29 days, patients in Argentina and Italy continued in an open-label extension. So this is a schematic presentation, and what is very important is the screening period. Very often, patients are called as non-responders, poor responders, but they're actually non-compliant. We basically performed blood examinations to determine if patients were taking the medication they were supposed to be taking. And to our surprise, a very large number had no drug in their plasma. The investigator swore the patient was taking, the patient said they were taking, the family member said they were taking, but there was no blood in the plasma. There were other patients in whom it was said the patient is on risperidone, and the blood analysis shows that they were actually on olanzapine. Or they were supposed to be taking one drug, and they were taking 2 or 3 or 4 drugs. This points out the necessity to ensure patients are compliant with medication. So what we did is we not only took the blood samples for analysis, but also looked at the concentration to make sure the concentrations were in the therapeutic range that the manufacturer and certain reviews have produced. By doing this, you get a relatively pure population of patients who are real inadequate responders, although it takes a very long time, because despite all the teaching, virtually every center has patients practicing polypharmacy, even though that has never been approved by regulatory authorities. So these are the characteristics of the patient population. Again, nothing very surprising, a mean age of around 40. As usual, we have about 70% of patients who are male, about 40% or so of Asian, and white Caucasians are about 54%. The illness duration was about 12 years. The current episode was about 10 months, so it's not recently exacerbated patients. The patients have been hospitalized at least 3 times for their illness, and the PANSS score at baseline is 79 with a CGI of severity of 4.4 to 4.5. The medications used by the patient are more or less in line with the market share, except for clozapine. The most common medication used was risperidone, followed by olanzapine. But to our surprise, clozapine was used in about 13-14% of this population, although the numbers generally seem to reflect clozapine is less used. The daily dose that was used in the 2 groups is listed on the right-hand side, and is fairly consistent with a high dose. I mean, the mean dose of risperidone was about between 5 to 6 milligram, with placebo getting a higher dose by 1 milligram. Now, the results from the study are very fascinating. Firstly, is just looking at disposition. In line with all the other studies done with evenamide, the retention rate is very high. Completing day 29 is 95% of patients. I have to say that I've never seen such high retention rates even in a 4-year study, a 4-week study. One patient dropped out due to death. Basically, this is a patient who committed suicide, and this patient had been randomized to placebo. The common adverse events, if you look at the treatment, the system organ class, there's nothing much to choose. Interestingly, if you look at the preferred term, again, there is no semblance of any increase in any CNS or gastrointestinal or sexual side effect. There are no weight changes. There are no EKG abnormalities. There's nothing of the type. It's very difficult for me to reconcile to the idea that we have an active antipsychotic but has no side effects. But this is what the data in over 600 patients to date seem to suggest. The primary efficacy measure was the PANSS total score, and that's the estimate. And as you can see, the treatment difference is about 2.5 points, with a p-value which is astronomically low, and a Cohen d of 0.33. The CGI of severity, which was the key secondary measure, also is significant in this study. Why is the treatment difference so low? This is a question which is frequently asked of me. First of all, these are inadequate responders. They are never going to improve by 12, 15, 20 points as you have in acutely sick patients who are newly diagnosed or newly admitted to a hospital. Secondly, these patients are on an antipsychotic, on a therapeutic dose of an antipsychotic. So even if they're not doing well, they're still benefiting from the antipsychotic. If you did not have the antipsychotic on board, the common assumption is that they would be worse by about 10 points. And last but not least is the fact that we restricted the PANSS score to 85 because we were concerned at first about how patients would do as outpatients. But as has been shown numerous times, the higher the PANSS score at baseline, the greater is the change from baseline. Looking at the efficacy measures, these are all the analyses requested by, generally by ICH, and you can see in each and every population, the p-values are highly significant. To my surprise, even the worst observation carried forward is highly significant, as are the analyses for multiple imputations. And this holds also true for the CGI of severity. Looking at the responder rate population, in these kind of patients, based upon Rosenheck et al. And Meltzer et al., we generally use 20% change from baseline. And as you can see, it increases over time, and at day 29 is approximately double of that of the placebo group. The placebo group, of course, here is an active control drug. Similarly, the CGI of change, and now you're not looking at minimal improvement, you're only looking at patients who met the criteria of much or more improved. And again, you see the same pattern, gradually increasing over time and coming out significant at day 29. This leads us to the design of the next phase 3 study. This is a 1-year study, placebo-controlled, screening period of 6 weeks, where we will definitely be testing plasma levels 3 times to make sure patients meet the criteria. All patients have to meet the TRIP criteria. They are randomized for 1 year. The primary endpoint would be 12 weeks. A second endpoint requested by CHMP would be at 26 weeks, and then the study continues for 1 year. The patients would be, again, obviously fairly psychotic with no upper limit on the PANSS. There would be an eligibility assessment committee to ensure that the right patients got into the study and there was no bias based upon investigator, sponsor, or CRO. So with that, thank you very much for your attention.
Again, we are tight on time, so please address your questions at the end, directed to Ravi. There are many questions on the Slido, so please come up.
Our next speaker is Dr. Carla Canoso. She is a psychiatrist and head of neuropsychiatric clinical development at J&J, and she's going to talk to us about monotherapy of esketamine. Carla.
Thank you. Well, on behalf of the J&J esketamine clinical team, I'd like to thank ECNP and the session organizers for inviting me to speak about this new data of esketamine monotherapy in patients with treatment-resistant depression. So these are my disclosures. So this audience is well aware that treatment-resistant depression is associated with chronicity, comorbidity, including medical comorbidity, and increased mortality, including mortality due to suicide. Esketamine nasal spray is a rapidly acting antidepressant. It is an NMDA glutamate receptor antagonist, and it's approved in over 75 countries for treatment-resistant depression, in addition to oral antidepressant agents. It's also approved for the rapid reduction of depression in patients with moderate to severe episode of depression that's considered a psychiatric emergency. But whether esketamine is effective as a monotherapy in treatment-resistant depression is an important clinical question, especially for patients who have experienced side effects such as weight gain or sexual dysfunction, but are receiving little benefit from their oral antidepressant. So I'm going to talk about a large study of esketamine in treatment-resistant depression, and the inclusion criteria was designed to be aligned with that was utilized in our phase 3 program of adjunctive esketamine to oral antidepressant. So the patients were adults, 18 years and older, and we even included some elderly patients in this study. They met criteria for treatment-resistant depression, having failed 2 adequate doses and duration of therapies in the current episode. They also had to meet criteria to have moderate to severe depression at study entry. With respect to exclusion criteria, to assist in minimizing functional unblinding, participants were not permitted to have had prior exposure to either esketamine or ketamine. We also excluded patients that had had ECT, VNS, or deep brain stimulation in the current therapy. Patients who were recently suicidal or homicidal were excluded, as were patients with moderate to severe substance or alcohol use disorder. So here's the overall study design, and it looks a little complicated, but it really isn't. We started with a screening phase of up to 7 weeks. So this allowed for safe taper of medication of any oral antidepressant that the patient was on, as well as a 2-week drug-free period prior to randomization. And then patients were randomized in a 2-to-1-to-1 ratio to placebo, 56 milligrams of esketamine monotherapy, or 84 milligrams of esketamine monotherapy. Now, during the screening period, patients were assessed for their severity, and those patients who had any sort of improvement in their MADRS score during the course of that screening period were permitted to be randomized, but weren't included in the primary efficacy analysis. They were, however, included in the safety analysis. Patients were studied for 4 weeks, double-blind. At the completion of the double-blind phase, they were permitted to roll over to an open-label period of up to 3 months. During that period of time, they continued to receive esketamine, but they could also have an oral antidepressant added back if it was necessary. And then they had a final follow-up visit. So for the purpose of this presentation, we're going to focus on the double-blind period, and here we see the efficacy analysis set. The patients had no improvement in their MADRS scores during the screening period, and that constituted 379 subjects. Here we see the disposition. As I said, there were patients who went into the safety analysis. There were about 100 of those. They came out for the efficacy analysis, and then you can see for each of the treatment arms during the double-blind phase, the overall completion rates were quite high, around 94%. If you look at the reasons for discontinuation, they're fairly similar across the treatment groups, though we did have a few more dropouts due to adverse events in the highest dose group of 84 milligrams. And in this program, unlike the program that we conducted in TRD with oral antidepressant, patients were started on 84 milligrams if they were randomized to that group, unlike the previous study where those patients were titrated up through 56 milligrams. So, as expected in a study of treatment-resistant depression, the patients were in their mid-40s. 2/3 of them were women. The study was conducted only in the US. The majority of subjects were white, although we do see some representation of other racial groups. Patients were chronically ill with mean duration of illness of about 3 years, and they were severely ill with mean baseline MADRS scores between 37, around 37. What was more surprising to me is that about 1/3 of the subjects entered study off of antidepressants, which suggests that some patients may have sort of given up on their oral antidepressant, even though they were continuing to have severe symptoms and quite a bit of chronicity. Also, about 1/3 of the patients had failed 2 treatments in their current episode versus slightly fewer patients having multiple failures in that current episode. So here we have the primary and key secondary outcome parameters. The primary endpoint was the MADRS at the conclusion of the 4-week double-blind period, and you can see that in the 2 active treatment groups, 56 and 84 milligrams, the difference from placebo was 5.1 and 6.8 points on the MADRS, highly statistically significant. Importantly, at day 2, which was essentially 24 hours after the first dose, patients also had a statistically significant and clinically meaningful reduction in their depressive symptoms, as reflected by MADRS differences of 3.8 and 3.4 points on the MADRS. Here you can see change over time with placebo represented in red and the esketamine treatment groups represented in blue and green. And the robust efficacy is reflected by the effect sizes of 0.48 and 0.63 at study endpoint. Response rates were at the study endpoint about double that in the 2 treatment groups compared to placebo, and 2 to 3 times higher on a remission rate as defined by a MADRS score of less than or equal to 10 at study endpoint. So highly clinically significant. So with respect to safety, again, this was the full analysis set for safety. The safety of the monotherapy treatment was very consistent with the well-known and well-characterized side effects of esketamine, with the most common side effects being nausea, dissociation, dizziness, and headache. Was very consistent with the well-known and well-characterized side effects of esketamine, with the most common side effects being nausea, dissociation, dizziness, and headache. So to conclude, esketamine as a monotherapy in patients with treatment-resistant depression at both 56 and 84 milligrams showed significant and clinically meaningful improvement in depressive symptoms after 4 weeks of double-blind treatment, as well as early as day 2. Throughout the 4 weeks of double-blind, the rates of response and remission were higher for the 2 doses of esketamine. The safety profile of the monotherapy was consistent with the well-established safety profile of esketamine from the prior studies. But these results provide important information regarding a monotherapy regimen for patients with TRD, especially for those who have already given up on their oral therapies. So to conclude, I'd like to thank my partners at Janssen, in particular study responsible physician Adam Yannick, who's here with us today, our partners at the investigative sites and the vendors, and importantly, our patients and families that participated in the study. So thank you.
Thanks a lot, Carla, for sharing that really exciting data. So we're changing flavors a bit and come now to substance use disorders. Unfortunately, a disorder we not always target in this symposium. So I'm very grateful that we can introduce Henri Aubin from Villejuif Hospital. I'm not sure whether I pronounce it correctly, in France, about a study on alcohol use disorder and using prazodine on cyproheptadine.
Oh, thank you for this very nice introduction. Good afternoon. I'll present the results of a proof of concept trial testing the efficacy of the combination of prazosine and cyproheptadine in alcohol use disorder. Very briefly, the rationale is that the simultaneous blockade of the 5-HT2A receptors and the alpha-1b receptors may restore the coupling of the noradrenergic and serotonergic neurons on the dopaminergic system, a coupling that is believed to be disrupted after a recent history of heavy drinking. In a series of preclinical studies with mice with induced alcohol preference, it has been shown that the administration of either cyproheptadine, chosen as a 5-HT2A blocker, or prazosine, chosen as a alpha-1b blocker, had no effect on alcohol preference, whereas the administration of the combination of the two drugs had a dramatic effect in reducing alcohol preference in this animal model, an effect that seems more potent than the one of reference drugs like naltrexone, nalmefene, or baclofen. So the selected subjects were randomized to receive a 12-week treatment of either placebo or a low dose or a high dose combination of cyproheptadine and prazosine. The main inclusion criteria was fulfilling the DSM-5 criteria for severe alcohol use disorder and reaching at least a high-risk drinking level as defined by the WHO during the 4 weeks preceding randomization. The study was conducted mainly during a period affected by COVID restrictions, so probably it's the reason why we didn't achieve the randomization of the planned 180 subjects. We randomized only 154 subjects, therefore the study may be underpowered. This is the main baseline characteristic of the included subjects. I just want to stress that more than half of the subjects had a very high drinking risk level at baseline, meaning that their average daily drinking was above 100 grams per day for men or above 60 grams per day in females. This is the results of the primary outcome. The main treatment effect across the three arms was significant. Therefore, we could undergo 2-by-2 comparisons that showed a superiority of the high dose of the drug combination compared to placebo at month 2 and month 3, with effect size reaching 0.44 at month 3. This is the same analysis in the subgroup of patients who had a very high risk drinking level at baseline. And in this subgroup, the effect of the high dose compared to the placebo appeared stronger and was significant at each time period, reaching an effect size of 0.51 for the high dose at month 3. This is the main secondary outcome, a change in the number of heavy drinking days over periods of 28 days from baseline to the end of treatment. And unfortunately, the analysis did not reach statistical significance for this outcome. This, again, is the same analysis in the subgroup of the subjects with a very high drinking risk level at baseline. And in this case, we had a stronger effect with the high dose of the drug combination versus placebo, reaching statistical significance at month 1 and 2, but not at month 3. This slide shows the other secondary outcomes. It's a busy slide. What it shows is that whatever the treatment, low dose or high dose, it was always more effective than placebo, albeit it was most of the time the differences were not significant. The safety profile of the drug combination showed no concern. With the high dose drug combination, there was an increased frequency of vertigo, fatigue, and dry mouth most of the time at the mild or moderate level. And importantly, there were no serious adverse events with the high dose drug combination. Because of the known adverse events with prazosin and with cyproheptadine, we did some specific safety measurements at each visit that showed no increased sedation or orthostatic hypotension with the drug combination. However, we did find a significant increase in body weight with both low dose and high dose of the drug combination, reaching 2.5 kilos in 12 weeks of treatment. This slide summarizes the effect size we found in this study that showed that we found a stronger effect with the total alcohol consumption endpoint compared to the heavy drinking days endpoint. We also found a stronger effect of the high dose than with the low dose versus placebo. And finally, with the high dose, the effect was increased in the subgroup of patients with a very high drinking risk level at baseline. This last slide compares the effect size we found with the high dose of the drug combination we looked at in this study with the effect size reported with the reference drugs in alcohol reduction studies. And our conclusion is that there is a promising effect of the combination of prazosin and cyproheptadine at high dose in the treatment of alcohol use disorder. Thank you.
So you have been very quick, so it would be possible in theory to ask 1 or 2 questions via Slido if there are urgent ones. Yeah, as you have saved us some time down the line. So please use Slido if you have questions. But if not, or if you need some more time, just do it while you're listening and or come up to the speaker after the meeting. Can't see any, so probably
Okay.
we continue. Thanks a lot.
Thank you.
Thanks very much. Our next speaker is Dr. Willie Early. He is a psychiatrist, and he's the head of clinical development at Intracellular Therapeutics, and he's going to tell us about lumateperone for MDD, a randomized trial. So, Dr. Early.
Thank you, and good afternoon, everyone. It's a pleasure being here today, and I want to thank ECNP for giving us an opportunity to talk about our phase 3 adjunctive MDD study involving lumateperone. So the studies involving lumateperone as a treatment in those MDD patients who failed to respond to antidepressants alone is in the adjunctive paradigm. As far as disclosures, I'm an employee of the company, Intracellular, and hold equity in the company. A little bit of background. As you all are aware, depression is one of the world's leading causes of disability. Patients have reduced quality of life, functional impairment, increased morbidity and mortality associated with suicidal ideations. While there are first-line treatments available for major depressive disorder, namely the antidepressants, we know that many of these antidepressants patients fail to respond sufficiently to antidepressants by themselves. In fact, it's been estimated that anywhere between 50% and upward of patients fail to respond to this first-line treatment. And as subsequent trials of antidepressants, even further decline in the response rate occurs. Historically, clinicians have used adjunctive treatments to try to mitigate some of the lack of response. Over the past 15 to 20 years, the use of atypical antipsychotic agents have been the mainstay. What I would like to talk to you today is about lumateperone. Lumateperone is a atypical antipsychotic agent currently approved within the United States for the treatment of schizophrenia and for depressive episodes associated with bipolar I and bipolar II disorder. Lumateperone is a mechanistically novel compound. It has a potent serotonin 2A receptor antagonism, dopamine 2 receptor antagonism postsynaptically, but presynaptically it works as a partial agonist. It also inhibits the serotonin reuptake inhibitor, and it has a D1 antagonism that indirectly affects the modulation of AMPA and NMDA. So our phase 3 trial, which was our first study looking at the adjunctive treatment of major depressive disorder, is really building upon the data that we have in bipolar depression. So our study was designed to investigate patients who failed to respond to
the simultaneous blockade of the 5-HT2A receptors and the alpha-1b receptors may restore the coupling of the noradrenergic and serotonergic neurons on the dopaminergic system, a coupling that is believed to be disrupted after a recent history of heavy drinking. In a series of preclinical studies with mice with induced alcohol preference, it has been shown that the administration of either cyproheptadine, chosen as a 5-HT2A blocker, or prazosin, chosen as a alpha-1b blocker, had no effect on alcohol preference, whereas the administration of the combination of the two drugs had a dramatic effect in reducing alcohol preference in this animal model, an effect that seems more potent than the one of reference drugs like naltrexone, nalmefene, or baclofen. So the selected subjects were randomized to receive a 12-week treatment of either placebo or a low dose or a high dose combination of cyproheptadine and prazosin. The main inclusion criteria was fulfilling the DSM-5 criteria for severe alcohol use disorder and reaching at least a high-risk drinking level as defined by the WHO during the 4 weeks preceding randomization. The study was conducted mainly during a period affected by COVID restrictions. So probably it's the reason why we didn't achieve the randomization of the planned 180 subjects. We randomized only 154 subjects. Therefore, the study may be underpowered. This is the main baseline characteristic of the included subjects. I just want to stress that more than half of the subjects had a very high drinking risk level at baseline, meaning that their average daily drinking was above 100 grams per day for men or above 60 grams per day in females. This is the results of the primary outcome. The main treatment effect across the 3 arms was significant. Therefore, we could undergo 2-by-2 comparisons that showed a superiority of the high dose of the drug combination compared to placebo at month 2 and month 3, with effect size reaching 0.44 at month 3. This is the same analysis in the subgroup of patients who had a very high risk drinking level at baseline. And in this subgroup, the effect of the high dose compared to the placebo appeared stronger and was significant at each time period, reaching an effect size of 0.51 for the high dose at month 3. This is the main secondary outcome, a change in the number of heavy drinking days over periods of 28 days from baseline to the end of treatment. And unfortunately, the analysis did not reach statistical significance for this outcome. This, again, is the same analysis in the subgroup of the subjects with a very high drinking risk level at baseline. And in this case, we had a stronger effect with the high dose of the drug combination versus placebo, reaching statistical significance at month 1 and 2, but not at month 3. This slide shows the other secondary outcomes. It's a busy slide. What it shows is that whatever the treatment, low dose or high dose, it was always more effective than placebo, albeit it was most of the time the differences were not significant. The safety profile of the drug combination showed no concern. With the high dose drug combination, there was an increased frequency of vertigo, fatigue, and dry mouth most of the time at the mild or moderate level. And importantly, there were no serious adverse events with the high-dose drug combination. Because of the known adverse events with prazosin and with cyproheptadine, we did some specific safety measurements at each visit that showed no increased sedation or orthostatic hypotension with the drug combination. However, we did find a significant increase in body weight with both low dose and high dose of the drug combination, reaching 2.5 kilos in 12 weeks of treatment. This slide summarizes the effect size we found in this study that showed that we found a stronger effect with the total alcohol consumption endpoint compared to the heavy drinking days endpoint. We also found a stronger effect of the high dose than with the low dose versus placebo. And finally, with the high dose, the effect was increased in the subgroup of patients with a very high drinking risk level at baseline. This last slide compares the effect size we found with the high dose of the drug combination we looked at in this study with the effect size reported with the reference drugs in alcohol reduction studies. And our conclusion is that there is a promising effect of the combination of prazosin and cyproheptadine at high dose in the treatment of alcohol use disorder. Thank you.
So you have been very quick, so it would be possible in theory to ask one or two questions via Slido if there are urgent ones. Yeah, as you have saved us some time down the line. So please use Slido if you have questions. But if not, or if you need some more time, just do it while you are listening and or come up to the speaker after the meeting. I can't see any, so probably we continue. Thanks a lot.
Thank you.
Thanks very much. Our next speaker is Dr. Willie Early. He is a psychiatrist, and he's the head of clinical development at Intracellular Therapeutics, and he's going to tell us about lumateperone for MDD, a randomized trial. So, Dr. Early.
Thank you, and good afternoon, everyone. It's a pleasure being here today, and I want to thank ECNP for giving us an opportunity to talk about our phase 3 adjunctive MDD study involving lumateperone. So the study is involving lumateperone as a treatment in those MDD patients who failed to respond to antidepressants alone. This is in the adjunctive paradigm. As far as disclosures, I'm an employee of the company, Intracellular, and hold equity in the company. A little bit of background. As you all are aware, depression is one of the world's leading causes of disability. Patients have reduced quality of life, functional impairment, increased morbidity and mortality associated with suicidal ideations. While there are first-line treatments available for major depressive disorder, namely the antidepressants, we know that many of these antidepressants patients fail to respond sufficiently to antidepressants by themselves. In fact, it's been estimated that anywhere between 50% and upward of patients fail to respond to this first-line treatment. And as subsequent trials of antidepressants, even further decline in the response rate occurs. Historically, clinicians have used adjunctive treatments to try to mitigate some of the lack of response. Over the past 15 to 20 years, the use of atypical antipsychotic agents have been the mainstay. What I would like to talk to you today is about lumateperone. Lumateperone is a atypical antipsychotic agent currently approved within the United States for the treatment of schizophrenia and for depressive episodes associated with bipolar I and bipolar II disorder. Lumateperone is a mechanistically novel compound. It has a potent serotonin 2A receptor antagonism, dopamine 2 receptor antagonism postsynaptically, but presynaptically it works as a partial agonist. It also inhibits the serotonin reuptake inhibitor, and it has a D1 antagonism that indirectly affects the modulation of AMPA and NMDA. So our phase 3 trial, which was our first study looking at the adjunctive treatment of major depressive disorder, is really building upon the data that we have in bipolar depression. So our study was designed to investigate patients who failed to respond to their current treatment of antidepressant. We looked at SSRIs, SNRIs, or other antidepressants such as bupropion. Patients had to have failed at least one, or a second trial of antidepressants was allowed. We looked at patients 18 to 65 years of age who had an MDD diagnosis but still unresponsive to the antidepressant. We measured it by having a MADRS score of greater than or equal to 24 or a CGI-S score greater than 4, as well as we looked at the patient-reported outcome, the Quick Inventory of Depression Scale, which is the QIDS-SR, and they had to have a score of 14 or greater. And so we measured inadequate response by those patients who had taking sufficient dose, as measured by the dose of the prescribed per label, as well as those who were on the drugs for sufficient duration. We described that as greater than 6 weeks. The study was designed, it was essentially a 9-week study, a 2-week screening period, a double-blind screening period, a double-blind treatment period where patients were randomized to either lumateperone or placebo as an adjunct to their antidepressant on a 1-to-1 basis, and then a 1-week follow-up period. Our primary efficacy variable was to change from baseline to day 43 on the Montgomery-Ashburg Depression Rating Scale total score. And our key secondary was the change from baseline to day 43 on the CGI-S score. We had additional variables, one for efficacy, looking at the QIDS-SR, as I mentioned, and we also looked at safety as well. As far as the study, we enrolled approximately 240 patients in each arm. The study was conducted globally, US, as well as about 6 other countries globally. As typically observed in depression studies, we had a predominantly female population around the age of 45. And we see here that the majority of patients had failed to respond to at least one dose of antidepressant. The majority of the patients in the study came into the study on SSRIs, followed by SNRIs, and then we had about 6% of the patients on bupropion. The baseline MADRS score, as I mentioned earlier, our entry criteria for MADRS was 24. We ended up having a baseline MADRS score of around 30 on both groups. And the CGI-S score was around 4.7 or 4.6 with both groups. As far as efficacy, again, efficacy was determined by change from baseline to end of day 43 or end of week 6. So we saw superior separation of lumateperone plus ADT versus placebo plus ADT at day 43. As you can see, the effect size here is around 0.61 and an LS mean difference of nearly 5 points. Not only did we see efficacy at the end of day 43, but we also saw efficacy at earliest time point measured, which was day 8, and it continued throughout the course of the study. In addition to the primary efficacy endpoint, we saw similar results with the key secondary endpoint, the change in clinical global impression of severity score. And again, we see the secondary endpoint meeting statistical significance with the LS mean difference of around 0.7 and an effect size of around 0.67. And again, similarly to the MADRS, we see the changes occurring as early as day 8 and continuing out to day 43. We wanted to also evaluate how the patients perceived improvement or not. And again, we see the similar findings as we saw with the clinician-rated outcomes. In the patient-rated outcome, the quiz SR, we see that the patients had a 2.4-point improvement on the quiz SR with an effect size of around 0.5. Moving now to safety, we had a slightly higher rate of AEs in the lumateperone group, 58% to 46%. There was one SAE in each group, no deaths reported in the study. The most commonly observed adverse event, and that's described as greater than 5% in the lumateperone group and twice the rate of placebo, there were 3, which were dry mouth, fatigue, and tremor. All of these AEs dissipated throughout the study. They were mostly mild to moderate in intensity. For example, the dry mouth and fatigue lasted around 3 weeks, and the tremor lasted 2 weeks. And they remitted 12 in the study as well. As I mentioned, the treatment-emergent adverse events were mild to moderate in intensity. And again, similarly to the study, they were mostly mild to moderate in intensity. For example, the dry mouth and fatigue lasted around 3 weeks, and the tremor lasted 2 weeks. And they remitted 12 in the study as well. As I mentioned, the treatment-emergent adverse events were mild to moderate in intensity. The mean changes on a cardiometabolic profiles were generally similar between the two groups, between lumateperone, 42 milligrams, and placebo. And the rates of potentially clinically significant weight gain, which is greater than or equal to 7% from baseline, were low in both groups. As you can see here, it was about 0.4%, and adverse events were also low, 2.9 in placebo and 6.2 in lumateperone. As far as the measurements on the SAS, the bars, and the AIMS, they were not significantly different. We did not see As far as the suicidal ideations, as measured by the CSSRS, we see about 2.3% for the lumateperone group and 4.4% for placebo plus ADT. In conclusion, lumateperone 42 milligrams as an adjunct to ADT demonstrated significantly meaningful difference from placebo with ADT on both the MADRS total score, CGIS, and the quiz SR total score. Lumateperone plus ADT was generally safe and well tolerated, and the safety profile is consistent with what we've already seen within prior trials in schizophrenia as well as in bipolar disorder. I wanted to also highlight that in addition to this study that I just presented, which is study 501, we have also completed study 502, which is a similarly designed study with around the same size of number of patients enrolled. And it likewise has shown efficacy on both the MADRS total score as well as the CGIS. We believe at Intracellular that these studies support lumateperone as an adjunct to antidepressants for the treatment of MDD. And we hope to file this data with the FDA at the latter part of this year. Thank you.
Dr. Early, just a minute. We have a minute. Okay, we have a little bit of time left over, so we have. So first of all, thank you for the talk of effect size of 0.6
Yes.
in these treatment-resistant patients is very impressive. And we have a question: do you know the occupancy on the postsynaptic D2 receptors on 42 milligrams lumateperone?
I don't have that exact number at this time, sir. Yes.
Okay, right. Thanks very much. Thanks again.
Thank you.
Okay.
So we stick with depression for the next talk, and I have to say that I'm very optimistic these days, and it's great to be a psychiatrist seeing that so many novel treatments come up. I mean, we have 3 new mechanisms of action for antidepressant drugs in this symposium, 2 of which are already on the market, and now yet another 3rd new mechanism of action introduced by Cohen de Mittenaere, psychiatrist at the University of Leuven, who will introduce aticaprant as a new treatment for depression with anhedonia.
Thank you very much for the introduction. Thanks to ECMP and thanks to the chairman for allowing me to share some thoughts on anhedonia, the assessment of anhedonia, and aticaprant, a kappa opioid receptor antagonist. We all know, and you said already, depression, we know a lot of things about depression, but the concept is still ill-defined, at least in my opinion. You all know that to meet the criteria for major depression, that you should have at least depressed mood or anhedonia, it is diminished interest or pleasure. Strange enough, in the DSM there is nothing about the lack of positive mood. A lot of people might think maybe that if there is a lot of negative mood, there will be low positive mood. But all studies show that the correlations between both are only in the order of minus 0.40, minus 0.35. So they are mainly independent dimensions. And then, so we say depressed mood is important and anhedonia is important. But you know that psychiatrists are strange people. They say it's important and then they don't look at it. If you look at the scales that are most frequently used, we heard already about the MADRS or the Hamilton. Anhedonia is a core symptom of depression, but in the 17-item Hamilton, there is only 1 score on 1 out of the 17 items that vaguely assesses anhedonia. MADRS is not much better, 10 items and only 2 scores on 1 item. Remember it because I'm going to come back on it. Inability to feel is somewhat saying about anhedonia. And it is important. Anhedonia and decreased positive affect are very important and are probably the most specific depressive symptoms. I'm not saying the most important, I say specific, differentiating best between depression and other psychopathological conditions. It's the main predictor of decreased life expectancy in depressed individuals. Lack of positive affect and anhedonia is a stronger predictor than excess of negative affect. It's highly correlated with cognitive deficit, social functioning, suicidality in depressed patients. The recovery of hedonic tone and positive affect got the highest ranking among patient expectations from treatment. Early changes, if we want to predict outcome, the early changes within 1 or 2 weeks of treatment, early changes in positive affect are more predictive of a good outcome than the early changes in negative affect. Remitted patients, standard scales, Hamilton or Madras, for example, they report normal negative affect, but still decreased levels of positive affect and hedonic tone. And to summarize it, we could even say that all the available treatments do better in decreasing negative affect than in increasing positive affect and hedonic tone. But anhedonia, it's a little bit talking about anhedonia or assessing anhedonia is for me a little bit of a Tower of Babel. And I tried to summarize a little bit all the different ways of assessing it. There's on one hand, there is the clinical phenomenological language, interest and pleasure, anticipatory and consummatory hedonic tone. And you should differentiate between what is sensory, the physical, and the social hedonic tone. Anticipatory is, I'm looking forward to. Consummatory is, I am enjoying. And there's a lot of scales trying to assess that. The gold standard is, but always be cautious about what is called a golden standard, is the SHAPS. But the SHAPS, for me, is a strange scale, because if you look at the item level, it always, I would enjoy. I'm not very sure what you're measuring if you ask to a patient, I would enjoy. There's a lot of other scales, the TEPS, the MAPSR, the SLIPS, the ASIPS, our own developed scale, the Leuven Affect and Pleasure Scale, and quite often there is also the use of a visual analog scale. So this is more the clinical phenomenological language. And almost far away from that is what you could call the cognitive neuroscience, neurobiological language, much more in line with the art docs. And there they talk about stimuli, readiness for reward, activating reward associations, feedback integration, energy expenditure, etc. A bit far away from what we feel our patients are talking about. And this is usually assessed with computer tests. And the question is it better to assess with computer tests or is it better to ask questions to patients? And then there is an attempt, at least one, to have a kind of hybrid language, and that's RISV scale, the DARS, the Dimensional Anhedonia Rating Scale, taking again the domains of the SHAPS, but being a little bit more precise. It is asking the patient for each of these domains to choose some activities, and then saying if there is interest, reward motivation, reward responsiveness, expected fun, and drive. It's trying to combine a little bit the clinical phenomenological language and the cognitive neuroscience language. This for anhedonia, the importance of anhedonia, and the difficulty in assessing anhedonia. And then aticaprant, a high-affinity selective kappa-opioid receptor antagonist. Maybe first some basis is that we all know that stress, substance withdrawal, and inflammation can activate dynorphin, which is the endogenous ligand for core, and that can release core. While moderate activation can be adaptive, excessive or longer dying core activation reduces dopamine release during reward learning and motivated behavior. Core agonists, they decrease the phasic dopamine release in the accumbens and also the 5-HT release, and they increase intracranial self-stimulation thresholds. Aticaprant has a high binding affinity and severity for the kappa-opioid receptor antagonist and is pretty selective because it's 30 to 200 times greater selectivity for core compared to the other neuropeptides of the endogenous opioid system. It is the DOR or the MOR. Receptor occupancy is there within 2.5 hours of administration and is substantially sustained through 24 hours. Aticaprant has the shortest duration of action of the currently existing kappa-opioid receptor antagonists. Clinical dose of up to 10 milligrams is expected to provide a robust and selective occupancy. And in rodents, it has been shown that combining eticaprant with imipramine, and in other studies with citalopram, produces synergistic effects on antidepressant-like behavior, like the forced swim test. And then, if we are in the development of new drugs in psychiatry, you all know that many drugs fail. Fortunately, today we heard some successes, but many drugs fail. And that's why in the NIMH, they strongly support what is called the fast fail approach. The fast mouse in mood and anxiety spectrum. It is that they push researchers and companies to have very early, in the very early phases of drug development, trying to have imaging data just to see if the compound engages the target in the brain, the target that is supposed to play a role in the disorder you're looking at, and does the compound measurably change a feature of brain function. A very good example here was Andy Crystal's paper and the research they did with aticaprant, looking at brain circuitry involved in reward and pleasure. And here are the results. It was fascinating results, very positive on the imaging data. It was aticaprant in an 8-week double-blind placebo-controlled trial in patients with anhedonia and a mood or anxiety disorder. Important to say, it was not only depression here. What you see, I won't go into detail, but you can see here with me that in fact everything which is green, without putting green, is statistically significant. And what you see is mainly the neurocognitive tasks, and especially the monetary incentive delay tasks, where for each of the tasks you have to perform, you first get a cue. Will there be a gain, or no gain, or loss? And then you have to perform the task. And you see all the measurements there, is it now the maximum activation or the mean activation? They're all statistically significantly superior, the activation, if you compare to placebo. However, if you look at the neurocognitive tasks, the PRT, for example, probability response task, then you see, it is one part is positive, one part is negative. If you look at the effort expenditure for reward tasks, no difference. Look at the self-rating scales of the patients, no difference. Look at the Hamilton Depression Rating Scale or the Hamilton Anxiety Rating Scale or the CGI, no difference. So a bit of conflicting results. And then there was this, to myself at least, a very exciting paper by Sabrina Darrow et al., where they went looking at these data and trying to understand a little bit better these discrepancies and this divergence between imaging data, neurocognitive tasks, and self-rating or observer rating scales. Look first at the left part of the slide. These are the correlations between the different measures. Let us have ventral striatum activation, follow the first row. You see, the correlation between the ventral striatum activation and the neurocognitive tasks is close to zero. The correlations between the ventral striatum activation and the psychological measures, the assessment, the scales, close to zero. The only good correlations is in between the scales, questioning the patient, self-rating or observer rating. What they then did was seeing, can we get a kind of latent trait analysis they performed just to see, can we split this patient population into two groups with higher and lower anhedonia, taking into account the imaging data, the neurocognitive tasks, and the scales. And we were able to differentiate in the latent trait analysis. The best model was a two-solution factor. But you see, there was a group with lower and a group with higher anhedonia. But they don't differentiate on the neurocognitive tasks. They don't differentiate on the imaging data. But they do strongly differentiate among the more subjective, you could say, questionnaires. And then, strange enough, if you were in the higher anhedonia group or the lower anhedonia group, well, the less severe anhedonia group showed a trend to have higher treatment response on the neuroimaging measure, on the probabilistic reward task, and on one scale, it was the functioning scale. while the more severe anhedonia subgroup showed the trend for higher treatment response on all the self-report measures. The authors are very honest in their discussion, and they say it is premature to rule out the utility of neuro or behavioral measures of reward based on the current secondary analysis. And then they say, yeah, maybe all these tests, all these neurocognitive tests, it's always about monetary gain. And maybe monetary gain is only one of the rewards we have in life. There's probably and hopefully other ones. Let's now look, and that's the last part of my presentation, just look at what is available from a phase 2 randomized clinical trial study investigating efficacy, safety, and tolerability of co-administration of aticaprant in patients with MDD who had an inadequate response to SSRI or SNRI treatment. Look at the left part of the slide, MADRS. You see a significant separation between aticaprant, adding aticaprant to the existing treatment, or compared to placebo. Highly statistically significant superiority. If you look on the SHAPS, the so-called gold standard for measuring anhedonia, then you see there is a numerical superiority, but not reaching statistical significance. However, and then I think this is an interesting here, left part of the slide again, then they split up the group with higher and with lower anhedonia and looked at what is aticaprant versus placebo doing to these patients. And then you see a huge differentiation on the depression, especially in the higher anhedonia group above. Interestingly, they looked at the item level, and I just put 2 circles on the 2 items in the higher anhedonia group, on the 2 items that gives the best differentiation between aticaprant and placebo. And that is inability to feel. Remember what I said in my introduction, that is the only item that somewhat assesses anhedonia, and lassitude. And lassitude has something to do with lack of anticipatory and consummatory pleasure. If you look at the SHAPS, I said overall it was numerical superiority in the total group, but not statistically significant. However, if you go to the higher anhedonia group, you got an effect size of 0.38, and that was statistically significant. Very briefly, what about the safety tolerability? No meaningful issues, no clinically meaningful changes in ECG, physical examination findings, vital signs, or lab results. Most commonly reported adverse events: headache, diarrhea, pruritus, and nasopharyngitis, and no effects on weight gain. In conclusion, I feel anhedonia is a core symptom of depression with a highly significant impact. It's a multifaceted concept, and the crosstalk between clinical and cognitive neuroscience language is still challenging. The DYNE-core activation reduces dopamine release while blocking cores interrupts dynorphin signaling and restores dopamine serotonergic release. Aticaprant is a highly selective core antagonist without abuse potential. We showed that it significantly increases fMRI ventral striatum activation during reward anticipation as compared to placebo. And the phase 2A trials showed that the co-administration results in a significantly greater reduction on the MADRS compared to placebo, with the strongest separation on inability to feel and on lassitude. And the improvement in baseline symptomatology and the increase in hedonic tone were more pronounced in patients with higher baseline anhedonia, with no tolerability or safety issues in this, of course, limited phase 2A trial. All this, in my opinion, strongly supports the further investigation of aticaprant in larger trials. Thank you for your attention.
Well, thank you very much, Koen, for sharing probably the best example of precision psychiatry in the depression space so far. I think this is the way we should go in the future, selecting the right patients for the right drugs. We are ending right on time, so thanks around for staying and have a great meeting. See you at the latest next year in Amsterdam. Bye-bye.